Hello everyone, I'm Dr. Tabinda, MRCPI mentor in StudyMedic, and I'm here today with the MRCPI written YouTube series, and the topic of today is infections in pregnancy. So these topics are from the Irish guidelines. One is varicella infection and the other topic is GBS infection. So we will be discussing these topics. So first of all, a little bit of the varicella virus. The varicella zoster virus is a DNA virus of the herpes family. It is highly contagious and it is spread by respiratory droplets and direct contact with the vesical fluid or indirectly via fomites. So which is the skin cells, the hair, clothing and bedding. In primary varicella zoster virus infection, which is the chickenpox, there is low-grade fever, malaise, and a pruritic rash, which develops into crops of maculopapules, and they become vesicular and crust over before they heal. And this is a very common childhood disease. And the incubation period is 1 to 3 weeks, and it is infectious 48 hours before the rash appears, and it continues to be infectious until the vesicles crust over, usually within 5 days. More than 90% of women are seropositive for the varicella zoster virus IgG antibody. Hence, the primary infection in pregnancy is uncommon. Following the primary infection, the virus remains dormant in sensory nerve root ganglia, but it can reactivate to cause the herpes zoster, which is called the shingles. In a dermatomal distribution, especially in immunocompromised patients with associated complications of encephalitis or pneumonia. Now, antenatal care and varicella prevention. So for this, the recommendations that the Irish guidelines give us are that the women planning to conceive should have their varicella status assessed and document the immunity status at the booking visit, and how that should be confirmed by taking the history from the patient if there is a history of varicella or 2 varicella vaccines, or by a lab testing which is of the IgG antibody following exposure. So we have to document that. Offer varicella vaccine to non-immune women in the postnatal period. It should not be given during pregnancy. Women with underlying medical conditions or who are on immunosuppressive drugs, they are at higher risk of severe varicella infection. So this should be documented at the time of booking. Pregnant women non-immune to varicella, they should avoid children who are ill with varicella wherever possible. Now, post-exposure prophylaxis for non-immune pregnant women. The recommendations for this are that after exposure, we have to assess the immunity status and the nature of the exposure. If immunity is uncertain, then a varicella IgG test is done. And if non-immune or if the immunity tests are pending, then we will isolate the woman with contact or respiratory precautions if attending a healthcare facility during her potentially infectious period, which is from day 8 to 21 post-exposure if they receive acyclovir or no prophylaxis, and from day 8 to 28 post-exposure if they receive varicella zoster immunoglobulin. And the administration of immunoglobulins might increase the infectious period by almost 1 week. If there is If there is significant exposure in non-immune women, give post-exposure prophylaxis, and that is oral acyclovir, which is the first line. And varicella zoster immunoglobulin, they can be used as alternative. Pregnant women exposed to varicella should contact their healthcare provider if a rash or fever develops in the next 3 or 4 weeks. If a woman has additional medical conditions or she is on immunosuppressive medications, then this should be noted. A woman with prior history of varicella or shingles may require post-exposure prophylaxis if she is on significant immunosuppression. Now, what about women who are pregnant and they are postpartum exposed at less than 6 weeks, and or they are suspected or confirmed with acute primary varicella infection? So first of all, we have to know that disseminated varicella infection in pregnancy can lead to hepatotoxicity and respiratory failure. And it is important that women with severe varicella are identified early and their care escalated according to national sepsis guidelines. So the recommendations for this is that we have to isolate the women in a single room if admission is required, and the staff caring for the woman should be immune to varicella. Women with disseminated varicella should avoid contact with other vulnerable people. And who are these vulnerable people? Those who are immunocompromised, who are on chemotherapy, or other varicella non-immune pregnant women, until all the lesions are completely crusted. In case of shingles outbreak, the lesions should be kept covered wherever possible. Pregnant women with acute varicella should be given acyclovir as soon as possible, ideally within the first 24 hours of the rash appearing. Now, what is the medication that we have to give? It is IV acyclovir in the dose of 10 milligram per kg every 8 hourly, and it is given at all gestations if they have severe varicella with organ dysfunction, that is hepatitis, pneumonitis, and encephalitis. So these 3 organs may be involved, and renal function should be monitored carefully. There is no role for the immunoglobulins once the rash has developed. Women with sepsis, that is organ dysfunction and suspected infection, should have their care escalated through the established pathways to high dependency unit or the ICU level, and they will be managed in line with the national sepsis pathway. Now, fetal exposure to the varicella in utero. What is the recommendation for that? The risk of congenital varicella syndrome is low. No increased risk of spontaneous miscarriage if varicella occurs in the first trimester. Risk of varicella syndrome, the fetal varicella syndrome, increases if infection occurs later in pregnancy. And the incidence with which they have mentioned is low. It is 0.5 to 1% with maternal infection in the first trimester and up to 2% at 13 to 20 weeks. And it is very rare after that. Recommendations for this is that we have to advise women to monitor for rash or symptoms for 8 to 21 days post-exposure if given acyclovir or no prophylaxis, and 8 to 28 days if given the immunoglobulins. And senior obstetrician has to be involved in the care of these women. Women don't require routine referral to a fetal medicine specialist if there are no symptoms of varicella post-exposure, unless there are concerns about the growth of the fetus or if there are any anomalies evident. Now, women with confirmed varicella infection, the recommendations for these are that we have to refer these women with primary infection in pregnancy to a fetal medicine specialist from 16 to 20 weeks of gestation and at least 5 weeks after the infection. Consultation with a neonatologist if there are fetal anomalies also evident. Counsel about the risks versus benefits of amniocentesis to detect the varicella DNA by PCR method. And we have to avoid the amniocentesis before the skin lesions heal and at least 5 weeks after the infection to minimize risk of a false negative result. If woman develops the primary varicella infection in the last 4 weeks before giving birth, there is an increased risk of the baby developing severe disseminated varicella, which would warrant antiviral treatment as soon as possible. Avoid elective birth till the infectious period has passed, and take care giving epidural or spinal anesthesia to avoid these vesicles. Mode of delivery: if fetal compromise or maternal respiratory failure is evident, then emergency cesarean section is recommended. It is strongly recommended that all the babies who are born to mothers with the acute primary varicella infection during pregnancy or birth, they should be referred to neonatology at the time of birth. Now, this is the algorithm that I've taken from the Irish guideline, and it is the same showing the pathway that we have to follow after exposure. So post-exposure prophylaxis for the pregnant women exposed to the virus. So first of all, you're going to know the immunity status of the patient. If she has a history of varicella infection or she has taken vaccines, and then we are going to assume them as immune and we do not need to give them any prophylaxis. But if there is no history and there is no history of infection or vaccine intake, then we are going to check her booking bloods for any tests which have been done for the varicella zoster virus, IgG. And if the IgG level is more than or equal to 100, then we do not need to give any exposure, post-exposure prophylaxis. And we will reassure the patient. But if the IgG level is less than 100, then we will administer the medicine, that is acyclovir, 800 mg 4 times per day for 7 days. And we will start the course on day 7 after the exposure, but can be started up to day 14 after the exposure. Now, neonate exposed to the varicella in utero at the time of birth or within the first week of life, what to do about that? Neonates who are born to mothers with chickenpox within 7 days before and 7 days after birth. This is a time period which is between 7 days before birth and within 7 days after birth. They are at increased risk of neonatal infection. Risk is highest with maternal infection from 5 days before to 2 days after birth. This is mentioned in the Irish guideline with the mortality rate of 30%. So recommendations are that babies whose mothers develop varicella in pregnancy at any gestation up to 7 days before birth, babies with in utero exposure to maternal varicella more than 7 days before birth, they should have a neonatal assessment at birth and at pre-discharge. And their mother should be encouraged to attend routine developmental checks. The risk of severe varicella infection following exposure of preterm infants, that is less than 28 weeks or less than 1 kg birth weight, to maternal varicella should be discussed with a senior neonatologist and infection specialist. And those babies whose mothers develop varicella either within 7 days before or in the 7 days after birth, now these babies have to get the post-exposure immunoglobulin prophylaxis. So this is recommended for them. But those babies who are exposed to the varicella in mothers who have had more than 7 days past, then you should only assess them. But over here, within the 7 days, if they are exposed to maternal varicella, then you have to give them the immunoglobulins. If a varicella-exposed baby develops any rash or febrile illness in the neonatal period, caregivers should contact the local GP or return to the local pediatric unit rather than the local maternity unit. They should be isolated in a single room to minimize risk of spread pending further investigation. Now about the neonate with confirmed varicella in the first month of life. We have to give them treatment with the IV acyclovir, and the immunoglobulin is not indicated once the rash develops. Investigate other causes for rash in a neonate, including herpes simplex virus and enterovirus as well. Recommendations are that we have to refer to the local secondary level pediatric center for assessment and treatment. Empirical IV acyclovir should be started in an unwell neonate with a disseminated vesicular rash, pending confirmation of other etiology. Babies with the disseminated vesicular rash, they should be isolated in single rooms with airborne and contact precautions. If varicella is confirmed, IV acyclovir should be continued in preterm infants, irrespective of maternal immunity. Those with respiratory compromise or those with severe end organ damage, and these cases should be discussed with local infection specialists. So here again, there's an algorithm from the guideline, and this is showing the use of the varicella zoster immunoglobulin in neonates exposed to the varicella zoster virus. Here you can see if the mother is the first index case, which is the first identified case. Yes, she is the one. Then we have to see if the rash onset was at less than or equal to 7 days before or at less than or equal to 7 days after birth. Then we have to give the immunoglobulin to the baby. And if the mother is not the first identified case, then we have to see that the contact of the mother was at less than or equal to 48 hours before the onset of that varicella or zoster rash. Then you have to see that if the baby is full term and at less than 7 days of age, then you have to ask about the maternal history of varicella, or we have to know the IgG status of the mother. And if it is positive, then immunoglobulin is not indicated for the baby. And if IgG antibody is negative, then immunoglobulins have to be given if at least less than or equal to 10 days of exposure. And for premature babies with low birth weight and in neonatal unit, we have to discuss with local infection specialist and manage in line with the NIAC guidance. So varicella and breastfeeding. About this, the women should breastfeed in isolation from other babies, other potentially susceptible pregnant women, and non-immune staff. They should be supported and encouraged to breastfeed if they wish. Vesicles on the breast, they should be covered to minimize the risk of transmission. If vesicles are present close to the nipple area, women should express that from that side and until the vesicles have crusted over. The expressed milk may be fed to the baby who is receiving the treatment with IgG immunoglobulins, with the varicella zoster immunoglobulin and or acyclovir. If the baby is not on immunoglobulins or antiviral therapy, then the expressed milk should be discarded. Acyclovir is not contraindicated in breastfeeding, so it is present in breast milk, but it does not cause any adverse effects in the infants. Now, reactivation of the varicella zoster in pregnancy, that is localized shingles. About that, shingles in pregnancy is typically mild. There is no danger to pregnancy and no risk of transmission to the baby. General complications of shingles are post-herpetic neuralgia, ophthalmic zoster infection, and Ramsay-Hunt syndrome and meningitis. These are the complications which can occur due to shingles. Administration of antivirals is most effective if started within 72 hours of the rash onset. Recommendations: fetal medicine assessment is not required as shingles is not associated with fetal varicella syndrome. In cases of disseminated shingles, infection control precautions are the same as acute primary varicella infection. Isolation in a single room with ensuite facilities under airborne precautions, and oral acyclovir can be considered in certain women with shingles, but this should be done on a case-by-case basis. Acyclovir may particularly be warranted if there is multidermatomal spread of the rash, involves the non-truncal areas, and that is near the eye, or the woman is immunocompromised. So we can have a few SBAs. So a woman who came from a country in the developing world had just had an emergency cesarean section for failure to progress. She was not sure if she had a past varicella zoster virus infection. She has been tested and found to be non-immune. Now she requests postpartum vaccination. What is your advice for breastfeeding? So in all these options, the answer is that it is safe to breastfeed. Studies have not detected the varicella zoster virus vaccine in breast milk, so women do not need to stop breastfeeding before or after the vaccine administration. So the next is SBA. A school teacher who is 10 weeks pregnant reports contact with one of her pupils who has chickenpox. Now, when would you say this child was infectious? So here are the different options. And the answer is 48 hours before the rash appeared and until it crusted over. That is usually after 5 days of the rash appearance. And another SPA, a pregnant woman in her 24th week of gestation reports contact with a friend who previously had shingles or herpes zoster. What type of shingles poses the greatest risk to this woman if she is susceptible? So, what type of shingles will be causing highest risk? It is the ophthalmic shingles. And herpes zoster poses a risk if it is disseminated or occurs in an exposed area of body, that is ophthalmic shingles, or in an immunocompromised individual where the viral shedding may be greater. The risk of infection following contact with herpes zoster that is not in an exposed area, that is, which is like thoracolumbar shingles, is remote, but it can occur also. So the risk of infection is highest with that of ophthalmic shingles, and it is less with thoracolumbar shingles. Now, the second topic is prevention of early onset GBS. So a little bit of information about GBS. Group B streptococcus, which is Streptococcus agalactiae, is the leading cause of severe early onset infection in the newborn infants. 36% of the babies born to the colonized mothers, they become colonized with GBS at birth, and 1 to 3% of these, they develop early onset GBS bacteremia. Early onset GBS disease occurs from birth to day 6 of life, and usually it presents with sepsis or pneumonia, whereas the late onset GBS disease occurs from day 7 to 90 of life and up to 50% with meningitis. GBS is also associated with an increased risk of preterm birth, endometritis, chorioamnionitis, and intrauterine death. That is why it is very important to know the GBS status of pregnant ladies. Risk factors for perinatal GBS transmission, they include rupture of membranes more than 18 hours before birth, rupture of membranes before the onset of labor, prematurity, and intrapartum fever. Each maternity unit should choose and implement one of the following GBS screening options. So the Irish guideline has told us about the screening options for GBS, and there are 3 methods for that. One is the risk factor based screening. One is the risk factor based screening enhanced by reverse transcription PCR testing of those at highest risk of prolonged rupture of membranes due to induction of labor or pre-labor serum, that is spontaneous rupture of membranes. And the third method is universal culture-based screening at 35 to 37 weeks gestation with the anovaginal swabs, that is. So there are recommendations about intrapartum antibiotic prophylaxis. Symptomatic GBS bacteriuria of any colony count, that is infection of GBS in the urine of pregnant mothers of any colony count, and asymptomatic GBS bacteriuria with a colony count of 10 to the power of 5, more than 10 to the power of 5 colony forming units. We have to give antenatal treatment as it decreases the risk of pyelonephritis, preterm birth, and low birth weight infants. So GBS bacteriuria of any colony count detected antenatally, we have to give them the prophylaxis in labor, and the woman should not be re-screened for GBS after that. And second is that if there is GBS vaginal colonization, for that what do we have to do? It doesn't require antenatal treatment, but IAP should be offered to these women. A history of GBS detected before the current pregnancy. For these women, offer a choice of IAP or repeat GBS screening. If a woman is known GBS carrier with pre-labor term spontaneous rupture of membranes, then you will offer IAP and also offer induction of labor as soon as possible. IAP should be offered in the following circumstances, that is GBS colonization in current pregnancy, and how we have found that by rectovaginal swab or midstream urine, or previous GBS colonization if there is during or previous pregnancy, if the woman chooses not to be re-screened in the current pregnancy. And if there is previous neonatal invasive GBS disease, and if there is pyrexia in labor, that is a single temperature recording of more than 38 degrees Celsius, positive intrapartum GBS PCR, prolonged rupture of membranes more than 18 hours. If the GBS status is unknown, then you have to give them IAP. Consider if there is a history of maternal invasive GBS disease also. Now the treatment. First-line treatment for IAP for people who are not allergic to penicillin. For them, you have to give IV benzyl penicillin, which is 3 grams IV stat followed by 1.5 to 1.8 grams IV every 4 hourly until delivery. IAP in non-immediate hypersensitivity reaction to penicillin. For them, you have to give IV cefuroxime, which is 1.5 grams every 6 hours, and it is the antibiotic of choice. IAP in immediate hypersensitivity reaction to penicillin. In these patients, you have to give IV clindamycin 900 milligrams every 8 hourly. It should be offered if the GBS isolate is known to be clindamycin susceptible. Now, GBS rectovaginal culture at 35 to 37 weeks gestation for clindamycin susceptibility testing be considered for people who disclose an immediate hypersensitivity reaction to penicillin. Otherwise, vancomycin should be offered for IAP, which is 15 milligrams per kilograms every 12 hourly. Maximum dose you can give is 2 grams. Pre-labor cesarean section where membranes are intact, in that case, IAP is not required, but discussion with the neonatology is advised if there is a history of neonatal invasive GBS disease, that is in the previous child. Now, care of infant. Each maternity unit should choose and implement one of the following GBS neonatal risk factor management options. So one of them is a clinical risk-based approach according to the NICE guideline, or the Kaiser Permanent Early Onset Sepsis Calculator. Investigations for sepsis evaluation in an infant by blood culture obtained in a sterile fashion and a full blood count. Lumbar puncture can be considered. The usual regime for EOGBS prophylaxis in asymptomatic infants is IV benzyl penicillin and IV gentamicin. Commence treatment with IV antibiotics, EOGBS prophylaxis for any infant who is symptomatic, an infant where a sibling in a multiple birth has a positive blood culture. Consider treatment where there is a history of invasive EOGBS in a previous sibling. Now, care for infants should comprise either regular monitoring of vital signs on the postnatal ward or a sepsis evaluation and IV antibiotics. Frequency and duration of observations 4 to 6 hourly for 24 hours. The overall condition of the infant should be monitored. Laboratories should send GBS isolates from sterile sites to IMSRL, which is the Irish Meningitis and Sepsis Reference Laboratory, for further analysis and sequencing to examine the national trends. Now, they have mentioned the risk factors for EOGBS and in infants, which are the maternal pyrexia, mothers having fever of more than 38 degrees Celsius within 4 hours of birth, if their membranes have been ruptured for more than 18 hours, if there is confirmed or suspected chorioamnionitis, if there is preterm delivery at less than 37 weeks, GBS colonization in current or previous pregnancy, GBS bacteriuria in current pregnancy. Now, atypical vital sign observations in infants, they include tachypnea, temperature instability, oxygen saturations which are lower than the expected age, and tachycardia, which is more than 160 beats per minute. Other symptoms may be that there is poor feeding, lethargy, apnea, seizures, and abnormal neurological examination, jaundice, encephalopathy, altered glucose homeostasis, and signs of respiratory distress. So there may be requirement for ICU care as well. Blood culture remains the gold standard for diagnosis of early onset GBS disease in infants. So the doses according to the NICE guidelines have been mentioned here. Now about the postpartum care in infants with the confirmed GBS bacteremia. Give benzyl penicillin monotherapy if no penicillin allergy present. Aim to switch to oral antibiotics once 24 to 48 hours afebrile. Treatment can be completed with oral amoxicillin. The total duration of IV and oral antibiotics usually lasts for 7 to 10 days, but the final decision on duration depends upon the complications if there are any. The woman should be advised that she will be offered the option of GBS testing or IAP in her next pregnancy as well. GBS colonization is not a contraindication to breastfeeding. So here is a chart about the management of intrapartum pyrexia. So you can see the different options with no penicillin allergy and with non-immediate penicillin allergy and with severe or immediate penicillin allergy. So you can go through these. It's the same that we have mentioned. And a few SPAs. So the first SPA, a 33-year-old woman has just had her second normal vaginal delivery. She is a known GBS carrier and received the loading dose of benzyl penicillin 30 minutes prior to delivery. So she has been given the IAP. She is otherwise low risk obstetrically and the baby was born in a good condition. So what initial management of the neonate would be recommended? So you can see all these now that the mother has been given the antibiotics. So what is the initial management of the neonate? The neonate will be having increased observation for 12 hours. Well babies of mothers who received IAP more than 4 hours before delivery do not require special observation, but well babies receiving IAP at less than 4 hours, then they should be evaluated at birth for clinical indicators of neonatal infection and have their vital signs checked at 0, 1 and 2 hours after birth, and then too early until 12 hours. So this is the answer, which is option B. The second SPA is that a woman who is 36 weeks pregnant attends the maternity day assessment unit with decreased fetal movements. She has no other symptoms and the CTG and the observations are all normal. A dipstick test of urine sample reveals 1+ proteinuria. The sample is sent for culture sensitivity. And the result is showing white blood cells more than 100, RBCs more than 4,200, and squamous epithelial cells are there. The culture is showing organism count, which is 10 to the power of 4 to 10 to the power of 5, and organism found is GBS. Antibiotic sensitivity is to erythromycin, nitrofurantoin, and penicillin. So what is the correct management over here? The options are no treatment required, offer IAP only, send a further specimen, and offer IAP if GBS is confirmed, treat with erythromycin now and then offer IAP, treat with nitrofurantoin now and offer IAP. So the answer is B, we are going to offer IAP only as she is at 36 weeks of pregnancy. Clinicians should offer IAP to women with GBS bacteriuria identified during the current pregnancy. Women with a GBS urinary tract infection during pregnancy should receive appropriate treatment at the time of diagnosis and as well as intrapartum antibiotic prophylaxis. So this is the answer to the last question. So thank you very much, everybody. Hopefully, this is going to be helpful for your MRCPI written exams. Thank you.